Thank you, Mr. Chairman, and thanks for Dr. Izzat Ali. I'm replacing my good friend, Dr. Mustafa Ibrahim Haya, and I'm going to talk about bariatric endoscopy, or تحديداً the part of role of endoscopy in obesity management. Well, it is quite hard to talk as an endoscopist, to talk in front of surgeons, and it's even harder to talk after my friend Dr. Khalid Gaudat, with all his deep philosophy that he presents within his talk. وده اللي بيبقى more valuable الحقيقة. لكن I will try my best. I'm going to talk about bariatric endoscopy, only the first part of bariatric endoscopy, which is what do we have as endoscopists to treat or to manage obesity. I will not talk about bariatric endoscopy in the sense of managing surgical complications. So as always, endoscopy is trying to mimic surgery. Surgery, they have malabsorptive techniques and they have restrictive techniques, so that's what endoscopy did exactly. Many techniques were developed which are restrictive techniques, starting by the balloon. And the balloon is an old idea dating back to the late 1980s. It was called Garen-Edward bubble. It was very small. It was can-shaped, so it caused a lot of problems, and it had some mortalities. It was discontinued, and then came back in 1996 with a totally new balloon, the spherical balloon, no pressure points, and it's adjustable. And انطلقت يعني from that point onwards. As for the restrictive surgeries, they are mainly at the small bowel level, and we're going to see some of them. What do we have new? We have more balloons. Not just the bioenteric intragastric balloon, but we have more. We have the BIB system that lasts for 360 days instead of 6 months. We have the reshaped balloon, which is 2 balloons in one. We have the Spatz, which is a balloon that's readjustable. You can pull out the part of the balloon and increase the size. And we have the ellipse balloon, which is the swallowable balloon, and it's very convenient for mild weight loss. It's a capsule balloon. The patient just puts the capsule in his mouth and swallows the capsule with water. The capsule is attached to a string, and then after the capsule is in the stomach, we know that by just simple X-ray. So after that, we start inflating the balloon inside the stomach. Once the balloon is fully inflated inside the stomach, I just pull the thread, and again, the valve is a self-adhesive valve, so you don't need endoscopy to do that. You don't need anesthesia or sedation. The patient is very much awake, and he swallows the balloon himself. After 4 months or 4 to 5 months, the valve of the balloon, which is a very large valve, not a small one, very large valve, it's biodegradable. It will just melt and then release the content of the balloon outside, and the balloon will move down the bowel and be expelled with the stool within 1 day with no complications. Other than balloons, yes, we've tried some other restrictive techniques as well, like the endoscopic, the POSE, the primary obesity surgery endoluminal, which did not gain much fame actually, because it failed to mimic the sleeve gastrectomy, because it left the fundus untouched. So we were only trying to grab the antrum and shrink the size, or make the size of the stomach a little bit smaller, but this procedure completely failed. It was replaced by endoscopic sleeve gastrectomy, and I know some of my friends in Egypt, they had a go at the endoscopic sleeve gastroplasty with some good results, but the long-term results are not available yet. So I cannot say that this is a recommended or an established technique for obesity management. We have some other techniques which were actually just more like ideas than techniques, like the transpyloric shuttle, which just dislodges in the antrum and the pylorus, preventing food from passing down. So I'm creating a gastric outlet obstruction. And we have the Aspire, and to my surprise, Aspire is FDA approved, the only one of the new techniques that is FDA approved. Aspire is a crazy idea. I don't even know if it will lead to some problems like depressive disorders or not. Aspire is you have a gastrostomy tube placed inside the stomach. The patient eats whatever he wants. After he eats, he goes to the toilet بيفتح الحنفية and he expels just everything he ate. The endoscopic bariatric procedure that is now gaining much fame is the endobarrier. It is not a new technique, it's quite an old technique. And the idea is more like a condom that covers the first 60 to 70 centimeters of the jejunum, and it's mounted in the duodenum by a tag. And there was the problem always, because this was not tolerated by the patient and they caused a few cases of duodenal blowouts. That's why it was discontinued, but it's now back with different materials. And there was a large international workshop about it in Japan, in India, just a few days ago. And it seems that it's coming back. The idea of the endobarrier is mimicking the bypass surgery. I'm trying to bypass the first 60 to 70 centimeters, which send wrong segments, endocrinal segments. That's why causing the delayed GLP-1 release and thus obesity. The same way we are trying to do duodenal mucosa resurfacing. And this means that I would like to cure the inflamed tissue of the first part of the duodenum and the first 60 centimeters of the jejunum, so I burn them. I use the balloon with hot boiling water through the balloon, applied to the duodenum, and then after healing, the healing will be with normal mucosa that does not send wrong signals. This is, of course, still not approved, all of them not approved except the Aspire. And again, a crazy idea from the endoscopists is the self-assembling magnets. You put magnets inside the small intestine, and the magnets will click with each other and cause iatrogenic fistula. So again, trying to mimic bypass. I will stop here. I will not talk about endoscopic management of bariatric complications. So we can see that we have a number of trials from endoscopists to mimic surgery. And my personal opinion about this, everyone can try whatever he wants, of course, within proper scientific protocols. But to apply this in real life, we have to be very, very cautious about this. Not everything that is being tried we can apply so quickly to our patients and into our practice. And from my practice, I believe that endoscopists and surgeons, they actually not compete. Rather, they complement and complete each other. I see a set of patients that are eligible for intragastric balloon because they are not eligible for surgery. And we see patients who can have the intragastric balloon because they do not want surgery. And the patient preference is always very important to address. Thank you very much.
Thank you, Professor Hossam. Elegant as usual, يعني to the point. وفعلا أنا سعيد جدا بالجملة اللي أنت ختمت بيها، لأن أنا أعتقد إنه الأوبيزيتي كان وحاليا وسيظل هو is a multidisciplinary problem. ما ينفعش أي part من التيم يكون excluded أو alienated أو متأخر حتى الدور بتاعه. ده أنا كمان بحب أقول إنه، ودي نقطة يمكن نقصانا شوية في التيم ووركس بتاعت الأوبيزيتي في مصر، الجزء مثلا بتاع السايكايترست والسايكايتريك ريهابيليتيشن، سواء اثناء الاوبيزيتي نفسها دايلاما او حتى بعد ما يعمل بروسيجر، لان هو اتس سوشيو سايكو بيهيفيرال بروبلم، ليها جينيتك باك جراوندز وليها ميتابوليك اوتكمز، ودخل فيها نيوتريشنست ودخل فيها فارماكولوجيك ثيرابي زي ما احنا هنعرف بعد فيو مينتس. اندوسكوبي يا اما بريدج يا اما alternative يا اما complementing. فانا سعيد جدا جدا بالجمله اللي انت ختمت بيها، لان هي دي فعلا تمثل الواقع. واعتقد انه هي دي الاسنس اللي احنا عايزين نطلع بيها من الجلسه. لو في اي اسئله للاستاذ دكتور حسام بيه اتفضل دكتور خالد.
حسام thank you very much. بس في حاجة واحدة مختلفة ان endoscopy will replace surgery. لأن what the current trends with industry, they're pushing so much for endoscopic sleeves and the magnets. You know who is pioneering the magnets now for bariatric surgery and bariatric interventions is Michel Garnier, who invented the sleeve gastrectomy, and to face the many failures happening, he wants to do a side-to-side duodeno ileostomy using magnets, and there are 3 or 4 groups in the world developing how to do this. So at the end, the endoscopists will do an endoscopic sleeve gastrectomy and add gastrogenostomy magnetic to that, so it's a gastric bypass. So probably with the efforts, good efforts of endoscopy nowadays, there will be a point in future you will replace surgery.
هو انا ممكن ازود كلمه على اللي حضرتك قلته يا دكتور خالد بيه؟
اوكي.
انا اعتقد يا بيه ان هم هيبقوا الاثنين اسمهم انترفنشنست، وان هم الاثنين غالبا ممكن هيورك سايد باي سايد. يعني انا اعتقد انه حتى ايفن يعني سيرجنز كتير هيبقوا برضو متعلمين اندوسكوبيك بروسيجرز زي اللي حضرتك قلتها دي، واعتقد احنا برضو هيبقى عندنا شويه
هم
اكسبيرينس.
حاليا بيقولوا لنا اتعلموا الاندوسكوبي عشان كده، بس طبعا يا ريت الاندوسكوبي تشيل يا بيسر.
تمام اتفضل يا
I
حسام.
may add لحضرتك يعني دي حقيقة، لأن احنا we see this as endoscopists for other fields as well, like the third space endoscopy مثلا، وقبل third space endoscopy كان النوتس. I think the endoscopy curriculum will change and the endoscopy training will change. We need to know more about surgery, we need to know more about pathology, because we have endoscopic enhanced imaging. يعني ده تكنولوجي رهيب. احنا بنتفرج على صور باندوسايتوسكوبي مثلا، is in vivo pathology. It's just that we cannot make sense of what we're seeing, but it appears to be that we're seeing very important pictures that we do not understand. So I think an endoscopy curriculum at a certain point in time will have to change to include surgical training and pathology training.
هو لحل المشاكل الخلافية دي البني آدم لازم اللي داخل بقه يكون قليل والمجهود يكون كثير. ده المشكلة الوحيدة. إنما احنا بنحتاج بقى الكلام خالد جودة وكلامك أنت ومصطفى، أما تبقى حكاية موربد ومفيش فايدة، أو في ميتابوليك بروبلمز أو في أمراض لازم يخس البني آدم. إنما هي بيزيكالي زي ما الدكتورة هتقول لنا الباطنية، ما تاكلش كتير وابذل مجهود كبير. ده الكلام. متشكرين.